usual, we have this wonderful program which has been organized by our Secretary Sujit Jos. He has put in a lot of effort, and it's actually been greatly appreciated by all of us in our AASK organization, and given us a lot of inputs and ideas about, especially fields in which we don't engage in on a daily basis. So today we are like concentrating about the wrist joint, right? Sports injuries, wrist joint in sports injuries. We have very eminent speakers, Dr. Sreekanth, Raveendran, who is a professor of hand surgery in CMC Bello. Welcome to you, sir. And we have Dr. Darshan Kumar Jain. Hi, Darshan. He's a hand surgeon in Jain Hospital, Apollo Hospital, Bangalore. And we have our friend Dr. Ajeesh Sankaran, who is from Al Shifa, not far from my place. Okay, so I'm sure, and the topics chosen also are like very brilliant. We have scaphoid fracture, how to deal with it in acute stage, and TFCC, which is always a nightmare to most of us, but it's not uncommon. It's a very, very, very common injury which we don't detect if we don't have a high degree of suspicion. But of course, even if we detect, most of the times we end up not knowing how to deal with it. So I'm sure these eminent speakers will enlighten us on that, and the perilunate injuries, of course, by Ajeesh Sankaran. So anything you have to say, Sujit, before we start off? Anybody else?
We'll start off with Dr. Binoy, who has organized all the good speakers, eminent speakers from all around India. And the rest is something which everyone wants to learn. I got many inquiries about when the program is, and people who could not attend were asking for the video links afterwards. So let's hope to have a wonderful session today. Over to Dr.
So the first talk is by Dr. Sreekanth. So the scaphoid is always a dilemma. So when we see the fracture, the first thing first of all, we like when we need to, whether you should fix it, whether you can leave it, if you leave it, and if it's not uniting, when you should start, thinking of fixing it, and whether you should, so many, confusions are there regarding the scaphoid. So I'm sure Sreekanth is the best person to enlighten us on the scaphoid fractures. Welcome, Dr. Sreekanth, for the presentation on scaphoid fractures.
Thank you, Binoy, and organizers for giving this opportunity. Let me start sharing the screen. I think I'm visible and audible. Am I right?
Yes.
Yes. I'm myself, Dr. Sreekanth from CMC Bello. And this is a very important topic whether to fix the fracture or just continue with the immobilization. Everyone knows scaphoid cannot be left alone. And I will just fix my topic about the identification of the fracture and whether it's stable or whether we can treat it operatively or non-operatively. So that's the topic, when to fix and when not to fix. Basically, it should be treated, and without you will just start with the presentation. So scaphoid fractures, basically it comes from 60 to 70% all couple, most common fractures, as you know. And the dimensions I actually showed you on these things, and it almost has around 2% of all fractures of the bone. So coming to scaphoid anatomy, scaphoid is not a simple bone. It's a twisted bone, and that's why it's called the navicular boat-shaped bone. And you have to understand that scaphoid mostly is on the volar aspect of the wrist, on the lateral aspect. If you look at it, most of the scaphoid is seen, distal to the central line of the scaphoid, and most of the actions happens, and the biomechanical also happens between them. That's, as I said, it's below the skin. And the vascularity is very important. I'm not going to the details. Basically, the vascularity comes from the distal and goes to the proximal, because the proximal part is basically intra-articular. You can see the dorsal and the volar scaphoid branch, and most of the vessels come from the distal dorsal branch. And coming to the acute fracture itself, basically because of the hyperextension of the wrist with the radial deviated position of the wrist, and can be the stage 1 of the perilunate injury. And mechanism of action is mostly fall on outside hands, and sometimes blow of the hand was hyperextension, and usually in the second to fourth decades, and mostly in the males. The other thing is most of the 40% of the scaphoid fractures are missed in the initial sessions. That's why called clinically scaphoid fractures, which of course most of the radiological examination cannot be seen in this X-rays. And when you come into the specificity and the usefulness of the clinical test, anatomical scaphoid tenderness, scaphoid tubercle tenderness, and scaphoid axial compressions. If these tests are positive, there is around 87 to 100% specificity and can only show 74% specificity. That means other injuries can be happened. And in acute fractures, only 18 to 28% are usually displaced. There is an Amsterdam rule brought up by the Mali who called the Cochrane review. That means male sex, swelling at the anatomical of solution, painful ulnar deviation, painful ulnar compression test positivity, the high chance of presenting acute fracture, even though the radiological tests are negative. And coming to the radiology, conventional radiology usually misses around 30% of the fractures. So if you, then the Cochrane study by Mali, it showed that in 1,000 patients, if you take CT, will miss 56 patients, but overtreat 8 patients. MRI does not treat any overtreat any patients, but still misses 24. And the least missed one is a bone scan, but it overtreats more than 100. That means more than 10% of patients will be overtreated. So coming to what are the conventional radiographies, scaphoid series, posterior anterior view, PAV with ulnar deviation, lateral view, and 45 degree semi-pronated oblique view are the most common. And these 4 view will detect around 70 to 90% of all the scaphoid acute fractures. This is the specific structural view with there is 20 degree angulation of the scaphoid to the axis. Basically, it's PAV with the 20 degree elevation, no ulnar deviation. If it is ulnar deviation, it's the Bridgman's view. And this is the best view for me for if you're doing it. This is really shows most of the fractures. Sitters is basically a hyperpronated, 60 degree pronated with ulnar deviation of the wrist and beam 20 degree. That means slightly elevated from the or in the scaphoid angle, which really shows all the fractures of the scaphoid. Carpal box by the Rockler can be seen, but they are very difficult and get cumbersome. And reverse oblique view also should show this hidden waist fractures. Basically, it is hyperpronated 45 degree with the 20 degree angulation of the view. Peritrapezial will show the distal fractures, and Robert's view can also show the distal edge or the distal tubercle fractures. Billiard's view is an easy fracture to show the inner displacement actually present in the scaphoid fracture. Scaphoid fast stripe, even though it's described, but the specificity and sensitivity is very less. You can see it's like the navicular scaphoid for the supracondylar fracture. And loss of scaphoid stripe view can cause, we can suspect fracture there. MRI is the most specific one. It is the second choice of imaging after this thing. And a smart trial in the UK, when they tried the cost effectiveness, is actually the best one, best view to identify early or hidden or clinical scaphoid fractures. And there should be a detection of the bone marrow edema and cortical breach by MRI. Can you hear me?
Sorry, Sreekanth?
Yes, sir. Yes, sir.
No.
Yes.
Okay.
We can.
Yes. So the T1 weighted image really detect the cortical breach. We have to identify the cortical breach in the MRI. It's the best view is T1 view. The stir and the other fat suppression view only shows bone marrow edema. That means there will be bone contusion also be there. But it's an indirect sign of the MRI. But if there is no marrow edema, you can be sure that there is no fracture. That is most important of this. This is an example of the false negative plain X-ray, which shows the bone marrow contusion and there's a break in the cortex in the T2 fatted image. And another false negative. You can see the T1 positive with the cortical breach and the bone marrow edema in that view. So MRI is very sensitive about and specific for the fracture site, scaphoid fractures in the acute settings. There's another with no contusion only marrow edema, no cortical breach. That is a contusion. It's not a fracture, but it can be treated conservatively. And taking CT scan, the best way is to take slices along the scaphoid. This is the article from Greg Bain, who actually keep the patient on his belly and takes cuts like this, so that along the axis of the scaphoid to see the fracture. Nowadays, because of the newer imaging technologies, the softwares, we don't need to do that. It just take it and they will orient along the scaphoid axis. So if you take a CT, make sure it is along the scaphoid axis. And CT is not a foolproof images. Acute fractures in 22% can be negative, but it can be used as a primary tool if the MRI is not present. And clinically scaphoid, that is negative X-ray scaphoid fractures, can be almost all detected by this, even though it is 22% is being negative. These are the examples of the scaphoid detected with this CT scan. And the CT scan be used as a role for the assessment of the displacement of the fracture, any combination, the percentage of union, especially in the partial union and the cortical collapse and interscaphoid angles. And the interobserver variability is very much less than compared to the MRI. Another important modification of CT is a dual energy CT, which can detect bone marrow contusion and cortical fracture, but it has not been available now. Coming to the most modern tool, that is the ultrasound. There are direct signs, which is the cortical disruption, and indirect signs, basically radiocarpal effusion and aesthetic effusion. If both direct and indirect signs are present, it's definitely a fracture. Only either is there, we need to confirm with MRI or CT. And elderly population, degenerative chemics changes can obscure the use of the ultrasound in the scaphoid fracture. So many studies have showed the specificity, but it is not as sensitive as for the MRI. Basically, sensitive almost like the radiographs only. This ultrasound showing this fracture can basically see the cortical breach. And coming to the acute scaphoid fracture itself, the natural history is not known, as said by the Joe Dyers from the UK. Prevalence is 0.14 in the non-unit. That means there are a lot of fractures which are usually united by itself without any treatment. So it's still a mystery how much will unite without any fracture. Unrecurrent scaphoid fracture union is rare because patient usually becomes symptomatic and wrist will collapse later. All acute scaphoid fractures need treatment, and risk of non-union, if not treated within 7 weeks, 4 weeks, it is around 40%. What are the non-union risk factors? Lay in treatment, as I said, more than 4 weeks or 28 days. Proximal pole fractures, fracture displacement more than 1 millimeter. Avascular necrosis or the avascular to the proximal pole, tobacco use, associated carpal instability like perilunate injuries. And how are the scaphoid can be treated? Treatment can be with this cast immobilization or with internal fixation. Can be a screw, or it can be plate, or any other modalities. So coming about the cast immobilization, coming about the fixation or not fix, the cast fixation. The fracture will unite with cast, do not fix it. If it will not unite with the cast instrument or cannot use cast, fix. This is a simple algorithm which I follow. I will come to it slowly. So what are the fractures will unite with the cast? Isolated stable fractures, which there is no carpal instabilities. And that means undisplaced or minimally displaced fracture. Earlier it was 1 millimeter by Cooney. Now, after the SWIFT study by Dyers, even less than 2 millimeter displacement can be considered stable fractures, and any distal pole fractures can be treated with scaphoid. There should not be any combination. There should be all should be close fractures. No greater or lesser injury. That means should be isolated. Patient should be complained. He should be come for close follow-up. And patient should have, if the patient is high demanding like sports injury young athletes, it's not a candidate for casting. And ideally, the treatment should not be delayed more than 4 weeks. And in pediatric scaphoid fractures, these should be fractures can be treated with cast immobilization, basically 6 to 8 weeks, depending upon the patient and the fracture personality. So these are the typical fractures. Distal pole and horizontal may unite with the casting. And these are the fractures will never, like transverse fracture, proximal fracture, vertical fracture, which goes unstable, never unite with casting. And coming to the outcome of the cast treatment, there are a lot of literature there. Basically, this is the consensus. Non-union fractures in this non-displaced fracture is around 10 to 12%, even though it's completely immobilized. Displaced fracture, especially in the waist, it is 18 to 50%, and proximal pole, it is 34%. And the relative risk of non-union, which is 7.5 more in proximal proflexion compared to the distal or waist fractures, and 4.4 times more in displaced or undisplaced fracture. And the average duration of cast treatment, even distal fracture, is around 6 to 8 weeks, and waist fracture, or it is around 8 to 12 weeks, around 3 months, and in proximal pole, it can go up to 12 to 24 weeks. Basically, should be very careful in fixing the proximal pole and should have close follow-up. Advantages is period of immobilization. Disadvantages is the period of immobilization, stiffness, decreased grip strength, and delayed return to work as usual with any cast. And cast has high the impact of fracture stability, the type of cast, and there is no literature support for high evolved cast. And the control of wrist extension and ulnar deviation gives the more union. Other things like ulnar deviation, thumb immobilization, elbow does not have any role. Only the control of the wrist extension and ulnar deviation, which can actually cause the scaphoid fracture to displace, should be reduced in any fractures. And immobilization, forearm rotation, or thumb immobilization does not have any role in the cast treatment. When to fix? All fractures that won't unite without rigid fixation, that is unstable fractures, high chance of non-unions like proximal poles, and any other associated injuries like open injuries, perilunate injuries, associated ligament injuries, distal radius fracture should be fixed. As I said, what are the factors causing instability of a coxal fracture? Displacement, perilunate injury, other combination, and the fracture patterns. Indication fixation again, absolute, displaced fractures, comminuted fractures, open, other associated injuries, relative is proximal pole, non-compliant fascian, or you cannot come for follow, and high demand like patients like in sports injuries. Method of fixation, a lot of armamentarium, can be open, limited access, percutaneous, and different like headless compression screw with metal, non-metal like a human allogenic cortical shaft, or even plate or staple. Scaphoid plate can be used for fixation with or without bone graft, but I like do when there is a combination in the volar aspect. Coming to our main treatment of fixation is the percutaneous scaphoid osteosynthesis or percutaneous scaphoid fixation. Can be done with a limited exposure. The advantage is post-op immobilization, early union rate, union has been faster, and early return to work other than the open fixation. Can be palmar or can be dorsal. Proximal, most important thing you have to understand is the scaphoid proximal and distal axis are not collinear. They are actually curved. The scaphoid is actually curved. If you want to fix a scaphoid from the distal or the proximal, you need a flexible or curved screw, which is impossible. The mean curvature is around 130 degrees. So best one is to fix depending upon the fractures geometry. Basically, we need compression across the fracture site, and the fracture line, the screw should be perpendicular to the fracture line. So coming to the central axis scaphoid, a centrally placed screw has greater stiffness and load to failure is less than that of the brace in the sides. Risk of cortical penetration more common in volar approach than in the dorsal approach because we are actually seeing it. And there is the dorsal cortex is narrower than the volar in volar approach. Usually the high risk of perforation is usually in the ulnar or dorsal zone. Practically, the coronal and sagittal axis of the scaphoid is like this. In the lateral view, you can see the trapezium actually prevents us to get into the central axis of the scaphoid in the lateral view, but we can actually drill through it, or you can use a osteotomy of the trapezium on the volar ridge and can get into that part. But more of the practical one is just between the distance from here and to the center of the proximal pole. This is the central screw positioning. And effective compression length is another concept where the longest pathway with minimal cortical cutout chance. There are different safe zones of the scaphoid. Basically, putting it, we cannot, as I said, it's a curved bone. So you start from, depending upon the fracture site, you have to actually change your scaphoid screw direction. Whether it's volar or dorsal, a simple algorithm is there, depending on the fracture location and surgeon's preference. For more proximal fracture, a dorsal approach is recommended in antegrade direction, and optimal screw placement in the central part of the proximal pole, which gives a better compression and better stability. Disadvantage is the wrist must be hyperflexed, and if you inadvertently extend the wrist, the guide wire may be bent, so then it will be difficult to remove, and associated extension tendon injury comes around 14% of the patients. Volar for more waist and distal fractures, scaphoid being placed from the distal to proximal within the scaphoid, wrist placed in comfortable supinated position, does not need to have extreme flexion. Extension of the guide wire may not happen. Disadvantage is, as I said, the trapezial ridge will be there, and greater difficulty in placing the wire in the centrally in the proximal pole. I'll show you the pictures. So, dorsal approach comparison is dorsal more parallel to the long axis scaphoid, perpendicular to the fracture line most often. Steve Moran said better for the B1 and B2 fractures, which is unstable fractures, and which can be managed with the dorsal approach. And Kang said dorsal and volar approach the same outset, except for the ulnar deviation was significantly greater in the volar approach, and occur in centrally placed volar compression screw fixation biomechanical advantages over the dorsal screw fixation. Percutaneous screw fiction that can be percutaneous or limited access. Slide in 2000 showed the narrow proximal pole to the wide distal fragment is easy for the central screw placement, and Chan however had more central screw placement in dorsal aspect, and Weinberg shown that there is around 12.5% of chance of extensor tendon injury. This is the different steps of dorsal approach. Basically, you have to flex the wrist to get the scaphoid bent or ring. Make sure the scaphoid is not, this fracture is not disturbed in this procedure. Find the center. Can be minimally opened or it can be percutaneous. Find the central end. We can use the crosshair technique where you can put K-wire in the distal pole, showing like this, so that you can aim the screw K-wire distally at the junction of this crosshair. And this is and drill through the scaphoid axis. You have to come through the trapezial or the thumb. This is the crosshair I have put, and this is the K-wire I'm pulling through the volarly. This is a dorsal one. Wrist is flexed, and the K-wire is pulled back. Another K-wire can be put just to prevent the rotation of the fracture, and the centrally placed screw can be used. Make sure all views should be taken. Okay. There is no cortical cutout. That's another picture. That's the union at 3 months. You can see the screw fixed from the dorsal side. No cutout on any side. Centrally spaced at ideal length of it. So the area of interest is the dorso-ulnar area where maximum cutout, which is like here. So this area we should be careful, and there are special views for finding it. Special view, 60-degree pronated oblique view for the cutout of the distal view. It's just like the situs view I actually showed. AP view with ulnar deviation, which shows the cutout in the proximal pole and other areas. Lateral view is very important as a dorso-ulnar, and if you do it in 30-degree supinated oblique view, we can see the dorso-ulnar area cut out very nicely. That's a supinated oblique view, 30-degree, so you can see the dorsal area cut out. And the new view has been described as the stand-in peanut view, which you take it around 30-degree supination, 45-degree ulnar deviation, 10-degree equation, basically show the central axis of these things. And medial cutout area should be also be careful, because as I said, the scaphoid is actually twisted, and 130-degree should be always in your mind when you do the cutout. Special views for that is the volar axial safe view, which we use for our distal radius like that. We have to make sure the scaphoid is bent like this. This is my view. You can see the safe view where the axis of insertion. Make sure it is not going into the dorsal or volar or even medial or cortical surface. Coming to the volar percutaneous screw fixation, even the dorsal we are flexing it here. We have to extend the wrist and not deviated, and draw the screw axis on the skin and apian and lateral view with the use of the IA. And trapezial ridge can be osteosomized or this. This is the way we do. We draw the line of the scaphoid in both the PA view and the lateral view, and from the joining of this line, you can actually start the thing. But make sure the trapezial ridge should be avoided, or you can use newer the SES set has a trapezial osteotomy set, which you can actually cut off the dorsal aspect, or even if open the STT joint without any clinical consequence. Basically, the volar pole of the proximal pole, 1/3, 2/3 junction, and to the center of the scaphoid, like this. And APB with oblique view actually shows the direction of the screw. That is the patient's X-ray after 3 months. So volar screw cutout views are the hypersupinated AP in comes of distal pole, medial and lateral cut can be seen. In pronated oblique, proximal cutout can be really seen. You can see this area. We can oblique view the dorsal oblique cutout, and should not go into the radiocarpal joint. Other screws have been available like Sharp screw. I don't have any experience, but it's been described. Open fixation, usually in the non-union fracture, can use a hybrid fixation just to show the steps only. Scaphoid staple has been described right now, but limited. Systemic review has shown that it's as effective as a screw, but it should be open. And coming to the pediatric fracture, 0.4 to 0.3 to 0.4% of all pediatric fractures, 2 to 3% of the hand fractures, and most often affected carpal bone lateral in humans, occurs around 11 to 17 years. Very rare in 8 years. Actually, the fracture can be completely cartilaginous or osteochondrous or completely osseous. That's the Tisane classification. And it has excellent results in treatment. Usually, this is a time for immobilization. And coming to all the treatment, most important, the return to sport or rate of return to sports is very important. Fixation 1 actually gives immediate return to sport in a cast. So cast should be avoided, and there is significant risk in a cast treatment. So all these patients should be fixed. And coming to the overall outcome of the scaphoid fracture fixation, union rate is around between 89 to 99. That means it's not a holy grail. Still, there is around 11 to 1% of non-union rate. There is 9 to 22% complication in the form of non-union, tendon rupture, infection, stiffness, everything. It's a technically demanding and there is a steep learning curve, but it is not a rocket science can be learned. Advantages is limited exposure, limited immobilization duration, early union, early return to work and sport. The predictors of non-union in acute fracture fixation is whether the volume of the proximal fracture, the more the proximal, more the chance of non-union even in the acute fixation. So it should closely follow for any other additional procedures. And even if it's more than 4 weeks, I said earlier, if it's more than 31 days, high chance of non-union even in the acute fixations. So I had to tell about the SIF trial by the Joe Dias. Basically, he said acute scaphoid wrist fractures displace less than 2 millimeter. If can be followed up closely, if you can pick up the non-union traits, it can be treated immobilization and it can avoid risk of the surgery and limited use of fixation. So CAST still has a role in scaphoid management, especially if it's undisplaced and reliable patients. Undisplaced or minimally displaced wrist fractures, I still CAST, but there is 10 to 12% of the non-union rate. We should closely follow up to identify them promptly. And union. So Singh has actually described in his experience, out of the 30 to 50 patients he followed up in CT, 30 actually had good union, and less than 12 patients had less than 50% of the trabecular. More in the radial side, the most chance of non-union. But others, if it is less than 25 in the ulnar side, it can progress to the union in a, you will just continue the immobilization. And if there is no signs, everything go smoothly, continue the cast. The dictum is, if all these things has 10 to 12% of non-union in cast treatment, you should be confident about the patient and confident about your follow-up. No hesitation to do the CT scan or repeat X-ray to find any fracture, any chance of non-union, and fix it. So there is a recent trend of primary fracture fixation. This is only one part of the slide. The rest of the thing shows increase in the percentage of non-union. This is from the US. There is no proper definition of acute fracture, but it shows the height, the rate of rising in the acute scaphoid fixation. In conclusion, if there is no confusion, there is a displaced fracture, unstable fracture, associated injuries, going to fix. If there is a confusion, undisplaced, minimally displaced fracture, cast with follow-up, you have to go secondary fixation. If you have no guts to wait or impatient, primarily fix the patient. Thank you.
Thank you, Sreekanth. That was a fantastic presentation. The conclusion slide was the best in that. So I have a few questions. Like, I mean, there was some excellent points. Like the clinical examination gives a more valid diagnosis than the X-ray itself. In your initial X-rays, you were telling that if there is a tenderness at the anatomical snuff box,
yes.
If there is pain with ulnar deviation. Am I audible?
Yes, yes.
Yeah. I'm sorry, I lost your audio.
No, I was telling that your initial slides, which was really interesting. Like that means the clinical examination is extremely important when it comes to the scaphoid fractures.
Definitely.
Yeah.
Yes.
So it is not the X-rays. It's basically the clinical examination. Like if the patient is having the tenderness at the anatomical snuff box, if there is a pain at ulnar deviation, and if there is a compression, thumb compression, these three things are more sensitive and specific than the X-ray itself. So that was
even
extreme.
Yeah. So there's something called clinically, clinical scaphoid fractures. That means it's usually the term in the UK they use because the availability of MRI and CT is limited in UK. So they will say it's a clinically scaphoid fracture, basically only on the this. That's why the Amsterdam clinical rule came. They come up with a score which is very robust, and that's why it didn't present. It actually, if you go look into it, Malley, who has done the Cochrane study itself, brought this thing. So if they say the submitted score is there, you treat it like scaphoid. And the SMART study which they brought, like whether you can use MRI or not, they say the 2 weeks of immobilization in the acute phase, the economic benefit in MRI outperform when if the loss of payment in the unemployment or other sort of incentives the government has to give to the patient.
And another question is like which if you have to take 2 X-ray views, which 2 X-ray views you will take to get an idea of the scaphoid fractures?
Basically, you have to take the ulnar deviated view and the pronated view. So the pronated view, I take 60 degree, that's the sitter's view, which actually shows the scaphoid like a seahorse. I call them, I tell my registrar as a seahorse view. It actually shows all the cortex. Even though it's slight overlap the capital in the proximal part, the whole sitter's view, you can see the fracture line. Now there is no revect. So the ulnar deviation, it's same thing. The proximal pole is nicely seen, and any fracture can be visible in that thing. And patients won't allow. If you cannot take the ulnar deviated view, means that patient has pain in the ulnar deviation, and that's an indirect sign of the injury. Okay.
So that means like the pronation oblique and the scaphoid view are the most important views when it comes to the scaphoid fractures. And suppose if it's like sometimes, is this concept true? Like you suspect the scaphoid fracture, you put a slab, and after 3 weeks, you remove the slab and repeat an X-ray to see the X-ray line. So fracture line, is that scientifically proven or?
Yes, if you see in the monk study and in one of the study, the Clemenston study, you can see that up to 30 to 40% of the scaphoid is missed in the primary stage. But maximum, even if it is up to 3 weeks, 10% of the fractures are not visible even in the radiology. So you will miss around 10%. You see the MRI in the Cochrane view, MRI misses 24 patients in 1,000, even in the acute state. But the sensitivity increase after time.
Okay, so
So there was a debate in our department. Sorry.
Yeah, so if you have to confirm a fracture, so the better option is an MRI than a CT, right?
Definitely. MRI, and we have to tell the radiologist, make sure there is a T1 weighted image along the axis and a stir or a fat image to see the bone marrow edema. If there is no bone marrow edema, that's the most important. Finding cortical is not that easy. You need good resolution in MRI, and if it bone marrow is present, that means either the contusion or the fracture. And if there is a bone marrow edema, I treat it like a undisplaced fracture. The ideal thing is you can wait for weeks immobilization. The pain is this. I definitely a cortical fracture or anything.
Okay.
The marrow edema must come down.
Okay. Thank you, Sreekanth. Is there any doubt like anybody is having? Can ask Sreekanth.
I have a question, Sreekanth. You mentioned about the fixation, which you could either do in the acute stage or later on when it goes to non-union. Is there any difference in the technique of you doing the fixation in acute and that you would do in a non-union, especially regarding the bone grafting or something which you would? Do you do it even in an acute stage, bone grafting? Or?
No, bone grafting, up to 6 weeks, we don't need any bone grafting. Basically, during the site, we actually try to open the fracture site. If you get traction, you can see it's stable or unstable. And most of the time, it will be stable because there will be some fibrous union will be there. And in my experience and in the literature also says, up to 6 to 8 weeks, we can still use the compression without bone grafting, and it will still unite. Only thing is, make sure that it is compressing screw, and the accurate measurement of the screw is very important because minimum 4 millimeters should be less than the actual measurement of the scaphoid dimension, and it should compress the thing and the thread should pass the fracture line.
Thank you, Sreekanth. Shall we move to the next talk, that is the arthroscopic TFCC repair by Dr. Darshan?
At the onset, I would like to thank the AASK Society and Dr. Binoy for providing this opportunity to speak on this topic. My topic is mostly on arthroscopic repair. So Binoy has told me to speak more about the repair, just not alone because TFCC tears are considered as a low back ache. So many times, many patients come to us about the ulnar-sided wrist pain, but how to diagnose is always a difficulty where every one of us find it. So I'm briefly touching upon on those points, but more of a surgical technique and the indications or the type of repairs what we do is the main focus of this presentation. So this is basically speak few words on the anatomy and how to diagnose. When to intervene is very critical because a lot of patients we find in our OPD, they keep coming with the splint wearing for 3 months, 6 months, even maybe sometime even for a year also. So when to intervene is critical, and methods of arthroscopic repair, that is what is the highlight of the presentation. So TFCC constitutes of both the dorsal and the volar radioulnar ligaments. Deep ligaments known as ligamentum subcruatum forms one of the deeper component of the TFCC, and it has got a central articular disc, a meniscus homologue, and the ulnar collateral ligament, ECU subsheath, and origin of ulnolunate and ulnotriquetral ligaments. So this is how, when you see on an end-on view, this is how the image looks. But a lot of them speak about this is one of the concept proposed like an iceberg concept. Basically, what we see is only the tip of what we feel is the tip of the issue. The much more bigger problems are the DRUJ stabilizers and the carpal stabilizers, which have to be evaluated whenever we see a patient with a ulnar-sided wrist pain. So many of them complain as basically the fall on an axially loaded and a pronated hand is what is the mainly, and dorsiflexed wrist is mainly causes a TFCC injury. And a lot of these injuries could be even like a torque or a twisting injury, which is one of the major cause of these complaints which we hear from the patients. And pain increases with the gripping and an ulnar deviation as well. So this is a basic classification given by Palmer. There are various modifications. I'll be just focusing mainly on the class 1, that is basically a traumatic. There is divided into class 1 and class 2. Class 2 are basically degenerative and class 1 is traumatic. It has class 1 is again subdivided into A, B and C, whereas A is called as a central tear, whereas B again can be subclassified into as a ulnar sided tear, where again it can be subclassified into bony involvement or as a soft tissue alone. And this is the distal part of the TFCC, that is the C type C, and radial, which is least common or not much of this thing unless it extends into the ligamentous part of this radial. That is what requires addressing to be managed. So these are the common tests which we see or we depend most commonly on. This is a foveal sign where the tenderness or the soft spot between the ulnar styloid and the FCU tendon. It has got almost 95% sensitivity and 87% specificity. And the ballotment test, which is very crucial when we want to know whether it's stable or not, and especially an instability on ballotment. A lot of times we may not be able to manage with arthroscopic alone. We may have to go in for surgical intervention as well. And this ballotment, excessive ballotment can be assessed or can be seen in mainly twice, that in two conditions. That is, one is while the patient is under anesthesia, you can check it well, or if it is a chronic event, that is another time you can assess this so significantly. Or else, a lot of them, judgment on this ballotment test is very difficult, even though it's a valuable, but you have to compare with the opposite side and come to this thing. There is no specific gauge to measure this per se. And the other things are the ulnocarpal stress test or the in neutral supination and pronation. That is also an important test where you stress it on the ulnocarpal, that is on the ulnar deviated. But again, it is sensitive but not specific because it can also be there whenever you have a ulnocarpal abutment or the TFCC or the LT tears or the degenerative arthritis as well. So this is the foveal test. The figure A is foveal test, B is basically the ballotment, and this is the ulnocarpal test. And this is the armchair test or the chair test, where when patient tries to load his wrist and tries to get up from the chair, he has a pain. So basically these two tests are not, that is the ulnocarpal and the chair test, are not so specific. They are sensitive but not so specific. So this is the ballotment test, which I was telling. And one has to, before we assess, we have to have a vague, an idea about these ligaments, or because topography or the surface anatomy marking is very important. Because as soon as the patient comes, the first important point we need to ask him to point out exactly where it hurts. That makes a lot of difference, because he might say all around, but you should ask him more commonly. You just point out one area which is most painful in this spot. So that helps us to go behind identifying the cause of this pain, because when we do an MRI, we may come across so many of them having TFCC tear, but we should know, is that the pain generator? Because or else we'll have an unhappy patient undergoing a surgery and then still not this thing. We'll be treating an MRI, not the patient's actual pain generator. So this story concept, or basically you divide this ulnar sided of the wrist into three columns, that is upper and middle and the lower columns, and then start examining is quite important. Very useful also. That is one of the articles on the ulnar sided. I have explained what are the causes. And the common investigations, what we do is the X-ray. And the variance is very critical. We need to do this thing, and we should not hesitate to ask or check for the opposite side of the wrist to know the variance. And the investigation is asked as true PA and not true AP view, or true PA and true lateral views are very critical. And this is how we measure the ulnar variance, just by drawing a line to the volar sclerotic line of the distal radius, which is perpendicular to the longitudinal axis, and the doom of the ulna. That is the distance between is what is taken as the mark. The other examination are the other things which we can ask is CT arthrogram, or the CT alone, or CT arthrogram and the MRI. I don't do much of these arthrograms. I would usually do an X-ray, and then if I have a doubt, usually I go in for an MRI, and preferably a 3 Tesla MRI. So arthrography, as I told, it is a bit tedious procedure, but definitely there is a role for this. It is not that it is not without role. It gives us so many times where MRI can miss, but arthrogram can still pick up some of these subtle tears which are not seen so much obviously in an MRI. There are a lot of studies. However, the interest is again rekindled. It was given up, but now a lot of people have started doing this again. So typically in MRI, this is how one has to look for the foveal attachment and the ligamentum subcruatum and the articular disc and the styloid insertions. These are the things. And also always try to have a look about this lunate, how it looks on an MRI, because an edema on this also rules out or you'll have to find out the other causes, like an abutment is helpful if at all there is a tear on the central disc or the radial side and a patient has the edema on the lunate. That means the abutment. Just repairing a TFCC is not going to help him. Then we need to look in for variants and try to manage that. MRI 1.5 Tesla has got a 84% sensitivity and 3 Tesla has nearly 35% of sensitivity. So this is various meta-analysis comparison. Even though it is a little bit of older study, it tells you what is the diagnostic modalities. Still MRI and MRA is recommended. And this is the article which I was telling that any patient while examining an ulnar site at West, you need to take time to examine. It is not simple because very high chance of missing the diagnosis because all that hurts on the ulnar side, it's generally taken as TFCC, but there are so many other causes. TFCC is just one of those causes. So this is what I was telling as a story concept. You divide this into 3 levels, upper, intermediate, and this thing. And you start assessing each of these joints like carpometacarpal, midcarpal in the upper story, and the intermediate is the ulnocarpal, and the lower is just beneath that is lunotriquetral and pisotriquetral on the DRUJ. And these are the conditions which you should most commonly look for because you can miss these things. And coming to arthroscopy, this is one of the gold standard finally means to diagnose a TFCC tear and also as a therapeutic. It can differentiate even pick up some of these chondral lesions as well. And TFCC tears have these loss of resiliency on protein, that is a trampoline test or indirect visualization of peripheral tears, that is a hyperemia along the periphery or tears along the LT ligament, and ECU sheath also can be sheath injury also can tell us that indirect signs that there could be a TFCC tear along with these. So trampoline test is basically you check for the ballotment of the articular disc and how good the trampoline is. So you probe it and find out. The other thing is the hook test. This is more diagnostic for the foveal detachment. However, there is a recent article mentioned by Jeff Ecker which says that just a positive hook test is not an indicator of TFCC, but you need to do a dry arthroscopic. That means you need to get into the DRUJ or the foveal part of this and look into, which is not an easy thing for a beginner. It takes some time for them to understand how to look into. And there's another ghost sign when you're doing an arthroscopic. This is what you open up the shaver end and just try to suck it. You can notice that the TFCC is raising up. So this means that there is a high chance that either he's got a foveal tear or even a big peripheral tear. Most commonly a foveal tear. You can see that when now it's down. The minute I open the suction, this thing, it rises up. So this also shows that there is you can see a dorsal tear as well, and it is very floppy. So the loss of trampoline, and easily you can lift it off. So you may not really require to go into the DRG to confirm here, but you may have to check it whenever you want to freshen the edges for these things. And what guides the treatment? Basically, it is a type of injury or the location of injury, that is the foveal or the dorsal capsular or the ulnar side or the distal side is what we want to repair. Radial side, not often. And the duration. Because as I told, first 6 weeks, we all want a lot of these TFCC injuries can be managed conservatively with cast or something. Anything non-subsiding pain more than 3 months, that is an indication. Unless an initial injury shows a significant initial imaging shows a significant injury and also clinically assessed by a lot of ballotment. And ulnar variance, of course, because that changes the whole plan of action itself. As I told, the treatment, this is the most commonly. And foveal tenderness quite significantly dictates the mode of treatment or even the possibility of intervention if it is not subsiding by 3 to 6 months. So surgical treatment depends on site. Debridement rarely we require, unlike because central tears rarely cause actually pain. That means you need to look for the abutment. And type 1A is usually you can debride up to almost 2/3 of the can be debrided, and the rest of them you have to try to retain. Type 1B, 1C, and D, conservative, DRG stable, and surgical if unstable. And not much with 1D, we don't arthroscopically repair unless they are combined with a dorsal and volar radioulnar ligaments as well. So this is a very big classification. I don't want to, but there are a lot of variations. Basically, it's just like splitting the head. But I think we should remember just both basically those PAMRs, class 1, A, B, C, D. That is very important for us. And as I told, timing less than 3 months, there's good healing, 3 to 6 months, because the healing predictability reduces, and more than 6 months, definitely the healing is reduced. So there are a lot of studies, but these are older studies, which proves that there is not much of a difference between arthroscopic and open. But recent studies definitely shows us that there is a significant benefit by an arthroscopic repair. And there is also other causes when you want to look in for an open repair. That is, you need to look as a forearm. Whenever you have ulnar sided wrist pain, you need to look into the forearm component as well. That is where an open repair might be beneficial, where you may have to do a reconstruction of the DRUJ, or you may have to do a distal oblique bundle reconstruction as well, or you may have to do a wafer resection as well. So this is another paper where open versus arthroscopic repair, again, they say it is not much of a difference. And recently the trend is more towards arthroscopic. And I just wanted to the main core of this is dorsal capsular technique for a few points on those. This is how we just most common we do just a dorsal capsular repair, which is very simple and easy to do. Basically, you pass 2 needles, and one of them is going to act as a shuttle. The other one can be acting as a the passing needle, and you can do this as a mattress sutures, or you do multiple mattress simple sutures as well. So this is what you pass it. That is as a shuttle. You can use PDS or the fiber stick or fiber wire 4/0 or 3/0. So you repair that. And that's how the capsular repair alone can be done. This is one such video of those dorsal capsular repair, where you pass those needles. And this is the fiber wire, which I'm using this, and the shuttle relay. Here you can bring both of them outside, or you can just retrieve it through that itself, there itself. So you reduce one step of that repair technique and then get it out. And then one has to be careful whenever you're suturing this, because there's a high chance that you could extensor digitorum, one of them, you can catch it, or even the dorsal cutaneous branch also you could injure. That is one of the complications when we see this. And this is another dorsal capsular repair where you do more of, you can see this is a dorsal capsular injury where you have a lot of hyperemia after 3 months of pain. Also, it's not conservative management, it's not. And you can see such a floppy this thing, and the edges have almost become blunt, and lack of vascularity on this. So we need to freshen these edges by arthroscopically. This is, we are viewing through the 3F4 portal and debriding those things through the 6R portal. So you debride then, ensure, because this was a very floppy this thing and a big tear. So here, instead of mattress sutures, I tried multiple simple sutures with just PDS alone. So that's the first stitch where you use as a 3/0 PDS. There are various configurations like Mason Allen and also combination. A lot of these combinations are there, whichever you are simple or which is faster or easy for you, you could use. So this is the third stitch. Then this is that second stitch, and then finally the third stitch. So all these things, then the final repair stabilized, you put outside a Nicky's knot or the sliding knot to get a good this thing. That's a small scar which you have. For all these repairs, arthroscopic repairs, I've stopped doing above elbow immobilization. Only when I do a reconstruction, I do above elbow, or a lot of these are just below elbow and slightly in neutral position. I don't ask them to supinate or pronate for almost 3 weeks, and then we start. There's another case where you can see the DRUJ arthroscopy, because this is a very difficult technique to learn initially, because you could either break the scope or damage the scope in various ways. So this is one of those. You are seeing the DRUJ. This is the radius and the ulna where this patient had. So this is literally inside you could use 1.9 scope is ideal for doing this. in larger joints, you could still get away. There's a lot of synovitis, you can see that. So, and even there is a chondral injury as well. Once you debride that, you can see it. So he had actually an abutment issue as well with lucky, but there was softening of the cartilage, but there was no loss of this central disc. So once you debride, you can see that the cartilage is damaged. Then actually we went on and did a wafer procedure for this type of injury. And this is another article where dry scopy is recommended to check the foveal attachment of the TFCC. So it's just like how you identify, a beginner finds it difficult to identify the rotator cuff tears. So this is something like that. So this is a normal TFC foveal attachment of through dry scopy. And this is where the unhealthy tissue, they are not so glistening, but a lot of fibrous tissues there. And this is the bare area of the TFC or the foveal attachment. So this is what you are seeing, the radiocarpal joint now. I'm actually trying to probe underneath that, and now I'm trying to get it to the DRUJ. I took out from the radiocarpal joint and trying to see the foveal attachment of the TFC. This is the foveal fibers which are going to the fovea. This is the insertion. You can see the consistency of the fiber here is different, and whereas once you go more towards the foveal side, it is much more. So once you debride that, you'll appreciate that the fiber consistency is much poorer. So that's why MRI picks up these as a foveal detachment. And if you feel that they are not stable enough, it is better to repair in this situation. So this is what I'm debriding the DRUJ, basically just underneath. So this is the normal fiber, whereas here as you go, this is just a fibrous tissue. And you can see slowly when I go through, this is the ulna head, which is popping in there. See, the fiber consistency is different. That is what this article says. So DRUJ scopy is critical. And foveal repair, you can do, for example, using a jig initially if you want. This patient had a distal radius fracture as well, and also inability to supinate. This went on for almost 4 months, and there was not much, and a lot of edema still persisted. So we tried to manage conservatively with physio, and still she also had ulnar styloid rim fracture or apical fracture. But finally, she had a lot of lack of supination. Once we did the scope, you can see there is so much fibrosis. A lot of arthropfibrosis was there in this joint. Probably that was one of the reasons also which prevented. So we cleared all this arthropfibrosis. Then the mobility of the joint was increased. This is a jig typically used by Nakamura, or the jig which is, it looks like this, where your 2 parallel guide wires are there. Initially, to get the hang, you can use finally, but with some time, you can even do a freehand technique as well. So these are the fiber stick which I'm taking through fiber wire. Again, lasso through that, pull it. I have made the bony tunnel already through this, and then loop it, and you can attach it with a knotless push lock outside, or even you can just put a knot through. If you have done 2 holes, you don't even need anchors for this type of transosseous tunnels if you make. So, and this is the kind of movement within 3 months after the surgery you can expect. So, and that's a minimal scar which you can see there. And even the much more stabilized wrist. So this is what is a jig which I was mentioning. There are a lot of other custom-made jigs which you can use. So to conclude, I would always try to remember to rule out the differential diagnosis. That is because TFCC repair, I'm sure anybody who has a little bit surgical technique, either he'll do it open, or if he's good in scopes, he can do it arthroscopically. But identifying the cause is the key, and don't try to treat only the MRI, and use a technique whichever is comfortable to you. And I would also like to welcome you all for the National Hand Conference in October coming next year. So we are going to have a lot of orthopods talking about this. Dr. Greg Bain is going to come. So I'm sure you will enjoy more of wrist and elbow in our Hand Society meeting as well. You're most welcome. Thank you very much.
Thank you, Darshan. That was a really fantastic talk. And that point in the, hello?
Yes, yes, tell me.
Yeah, that point was very true, that we should not try to treat the MRI. Many times we see the MRIs with which is reported as the TFCC, and even if you, many times, I mean in Kerala especially, the patient trusts the MRI than the doctor. I mean, that's what I felt. So even if you tell clinically that, okay, it doesn't look like an MRI, and you do that, they just don't, budge. So when you do the scopy and you don't see it actually. So that is actually extremely important that we should not be taking the MRIs. And so like you are telling that the first 6 weeks, the mainstay of treatment is conservative. So is there any indication for you to go ahead with a scopy in the first 6 months?
If I see feel that clinically, sometimes some patients, if I feel there is ballotment, because a lot of them may be having pain, so sometimes I inject a local and check the ballotment on the opposite side. Those are the cases if they have already done this thing and very frank foveal detachment, it is mentioned, and clinically if they come early, so there I tell them, and the young individual demanding athlete, definitely fix it.
Okay. And that the best time for the repair is 6 weeks to 3 months.
3 months is really, you can get good results, but after that it's not. We counsel the patient and then do, because as you saw in those DRUscopy, actually that is where it makes a lot of difference, because everyone tries to see the TFCC through only the radiocarpal joint. That is where the problem starts, and they cannot really even have, when you're doing arthroscopy, you're not able to identify is there really something torn or not, because there you might feel even trampoline test, hook test, but when you do a DRUscopy, a lot of things fall in place and you'll get an better idea of that.
Okay. And how often do you have to, when there is an ulnar variance, how often do you do a shortening with, do you do anything with the TFCC, or you just do the short?
Very rarely I try to. If at all the variance is 3 millimeter, I just do a wafer, and more than that I do shortening. But rarely I think I have the need was there for me to do it, because a lot of these times the TFCC would have been already torn by the time they reach to us. Like the multiple repeated impaction, there will be central tear or something like that. So
okay. Thank you, Tarsi. Is there any questions like for Darshan?
There is a question in the chat box from Dr. Jyoti. Can you elaborate on the wafer procedure?
Okay, I could have shown you a video itself. That is a short video. See, wafer procedure, basically what we do is mainly whenever you have a variance difference of the opposite side, because comparison is important, get a true PE and true lateral and try to check if at all only more than less than 3 millimeter variance is what you can address with the wafer procedure, or else you cannot. And also the certain points one has to take care is should not violate the DRUG. When you are taking off this thing slowly, because there is a high chance that your burr can rub into the sigmoid notch of the radius, which you have to be careful on that. And you have to, the initial first part, you have to look at the MRI. Is there really that injury is also, because you should have a reciprocating lesion on the lunate. That is the only diagnostic criteria. Then you try to do. So 3 millimeter using burr and confirmation preoperatively by MRI. So this is what I can share the link on the wafer procedure if you want. On my YouTube channel, there's a how to do about this on the wafer procedure. It's a very easy procedure, but identifying the case is very critical in these things.
Talking on the wafer procedure again, after the wafer, it makes the distal end of the ulnar a little rough, isn't it? So do you try to reduce it further, or do you keep it at the level of the radius?
No, I'll just bring it just the different. I see the measurement opposite side, and that is what we try to. So usually the burr tip is a good indicator for us to know how much is it, because it is under traction. It is very difficult to assess per se. You may see under CIM, still you will not be confirmed. But usually what burrs we use is generally 2.4 mm. That is what is the size of burr which I use. So that gives me anything, the burr dips beyond that, that means beyond the sigmoid notch, or it stops. So that is where I would try to keep it. That's the easiest way to judge intraoperatively. And one other important point is you need to supinate and pronate and check, because a lot of times what you are seeing through the tip is only one half of this thing. You feel you have taken it off. But when you see actually in the C-arm, you might be surprised that you have not even taken off 10% of the ulna actually. So you need to supinate and pronate and take off on all the angles so that the abutment is lost. It means it's reduced. I can, in the chat box, I will share you the link of that wafer procedure surgical video on this thing as well. So you guys can look at it. Anything else?
Is there any more questions to Darshan? Shall we move to the next speaker, Dr. Ajeesh, on perilunate injuries?
Yes. So is that visible?
Yes, yes.
Okay, yeah. So thank you to AASK and Dr. Binoy for this opportunity. So yeah, so I will be talking on perilunate injuries. Quite common, we see them quite often, and we tend to get carried away with the terminology of what is a perilunate, what is a lunate. And so the perilunate dislocation is when the lunate actually stays in the lunate fossa. It's the carpal bones that dislocate relative to the lunate. And the lunate dislocation is when the lunate dislocates, but the rest of the carpus stays aligned. But the thing is, whether we call it a perilunate dislocation or a lunate dislocation or a fracture dislocation, they all sort of form part of a spectrum of injuries which are called the perilunate injuries. And so we should be treating them, we should be understanding them and managing them as part of a spectrum of the same sort of injury process. So, yeah, so these are often high energy injuries, quite common in our setup because of the use of motorcycles. They are pretty common when with the fall on the outstretched hand with the wrist and ulnar deviation. They're considered to be about 5% of all wrist fractures. The entire spectrum is considered to be about 5% of all wrist fractures. And from the initial days, from the 90s, when these were first, I think, described and classified, even till the modern times, about 25% are still considered to be missed initially, and from the initial trauma X-rays which are seen in the ER or elsewhere. And of course, they are a significant cause of burden for the patients when they're missed initially. So before we go on to the more details on the perilunate injury and its management as such, I think there's some basic understanding of the wrist ligaments is required. One is on the dorsal side, the important ligaments are the dorsal intercarpal ligament, the dorsal radiocarpal ligament. So the dorsal radiocarpal obviously runs from the radius through the lunate and onto the triquetrum on the dorsal, and the intercarpal is approximately along the midcarpal joint dorsal. And the intrinsic joints are between the carpal bones, and those would be important ones would be the scapholunate and the lunotriquetral ligaments in the proximal row. On the volar side, the circle marks the space of Poirier, which you may have heard is one of the weakest parts of the wrist capsule. And that is through where the capitate or the lunate tends to dislocate. And the space lies between, there's a proximal inverted V sort of an arrangement of ligaments, which is a long radiolunate from the radius onto the lunate. And then there is the ulnolunate. That together they form a proximal inverted V. And then there's a distal inverted V between the radioscaphocapitate and the ulnocarpal. So between these two V's is a small space where the capitolunate joint lies. And that is the weak point through which this injury occurs. So straight away first, the important point is not to miss these injuries. So on the wrist radiograph, when you're looking at a PA view, and we've all heard of these, the Gilula's arcs. So there are three arcs to look for. One is the proximal arc of the proximal row, then the distal arc of the proximal row, and then the proximal arc of the distal row. So there are three sort of concentric. They're not exactly concentric, but then these arcs, three of them to be looked at. And usually they are smooth and unbroken. And whenever we have a problem, whenever we have a confusion that there might be a break in any of these arcs, that is when we should suspect and try to investigate that further. And on the lateral views, I think generally people are not often used to looking at wrist X-rays find the lateral view extremely confusing. And the important point is to first realize where the capitate is and how the capitate then lies upon the lunate, of course, the arc of the scaphoid, and then how the lunate lies on the distal radius. So this appearance of the capitate, the lunate, and the radius in one line is what is called the apple in a cup in a saucer, which is an important point to know, not just to diagnose the perilunate injury, but even post-operatively to assess our reduction immediately post-op or even later when we remove the wires. So the apple in a cup in a saucer, this collinearity of these bones is an important one to look at to assess these injuries. And the red flags, whenever we see a patient with a swollen wrist, especially who's a polytrauma patient and maybe unconscious, or conscious patients who complain of paresthesias, we definitely have to get wrist X-rays and investigate them further. So in the modern series, what you see is most of the missed injuries actually come from patients who had other injuries, and therefore the wrist part was not initially looked at. So it is important that whenever we find any of these red flags, that we get a proper X-ray, get proper X-rays of the wrist and evaluate it further. For example, this patient is what would be called a lunate dislocation, because the lunate is now flipped over towards the carpal tunnel. So that's the lunate, that's out of that. And then the same X-ray, if you look at the AP view, there's another finding that is often visible is what's called a triangular lunate. So when the lunate is flexed, it gives this triangular appearance. And that, of course, in a lunate dislocation, and there may be other causes of whenever there's a scaphoid deformity, you may have a triangular appearance. So this triangular lunate is also another red flag sign that you should be looking for in a PAV. So the Mayfield stages is customary to have this slide in perilunate dislocations to show what the Mayfield stages are, and this basically tries to tell us how the injury progresses. But this study, this biomechanical study by Mayfield and Johnson, was from the 1980s, and this really has never been redone or confirmed after that. And then, of course, other than mechanisms described, is called the reverse Mayfield. The basic idea is that the injury, it occurs, it progresses all around the lunate, basically in a clockwise fashion, if you're looking at it like this, starting from the scapholunate area, and then on to the mid-carpal, which would be an injury to the radioscaphocapitate ligament and the dorsal intercarpal ligament, then the lunotriquetral, and then finally to the dorsal radiocarpal. So this injury seems to go all around the lunate, and that is, of course, why we call it a perilunate injury. And the importance does not really lead to any great clinical importance, actually. But the importance lies for me in understanding on what are the components of the injury that need to be managed, and that you ensure that each of these components are managed rather than a theoretical understanding of how this injury has occurred. So we'll see that. So this, when you look at this X-ray, this is a trans-scaphoid perilunate injury. And quite clearly, there's a scaphoid fracture. The lunate shape appears abnormal. That is all towards the triangular side. And on the lateral view, you can see that the lunate appears slightly flexed. And of course, the apple is not in the cup, because the capitate is dislocated dorsally. And once we complete the fixation, this is how this case was managed. So the importance of understanding probably the Mayfield stages lies in understanding why this fixation works and why we should aim for this sort of a treatment. The first is that we have fixed the scaphoid with the screw. So that would be the stage 1 sort of injury, where we have taken care of the scapholunate or the scaphoid injury. Then we have fixed the scaphocapitate, which is the stage 2, or where we have fixed the midcarpal component. And then the lunotriquetral, which is fixed with 2 K-wires. So the fixation, or the idea of the fixation, we can understand it better if you understand the Mayfield classification. Otherwise, I don't think there's any theoretical point to it. And we tried to avoid having any implants or anything across the capitolunate joint. Midcarpal is often fixed either from the scaphocapitate or from the triquetral to the capitate. And then, of course, often we don't try to fix the radiolunate as well. So the radiolunate, we may need to fix temporarily for correcting the deformities in the lunate, but usually you do not have these fixed as part of the final fixation. So then, if you look at the lateral view of the same patient, we see that the scaphoid screw and the K-wires are in place. The important point to understand is, of course, when you look at the capitolunate junction, the capitate and the lunate are now reduced. And generally, the axis is now in a straight line. The capitate, in fact, the metacarpal, the capitate, the lunate, and the radius are now one axis. And that shows that we have achieved a good enough reduction for this patient. And that is a reminder of how that appearance should look post-operatively. So the approach is going to be, now commonly the one done is dorsal. There can be a volar approach as well as a combined dorsal and volar. The volar is often not performed now. There are older papers about volar approach to the perilunate, but now is often not performed because most of the injury components can be accessed from the dorsal aspect. And then there are reasons for doing a dorsal and a volar approach, like a median nerve decompression, etc. And we'll come to that. And I think over the last few years, the arthroscopic approach is also becoming more prominent. I have no experience with that, but that is slowly gaining importance as well towards fixing the scaphoid fractures and try to repair the ligaments through an arthroscopic approach as well. So the dorsal approach, these pictures are from Dr. Praveen, beautiful pictures, step-by-step pictures on how to access the wrist in this sort of injury. So usually we give a straight dorsal incision, That's the EPL, that's the third compartment. And once you retract that, you straight away find that there is a capsule rupture, which is the usual pattern that we find in these injuries. And now to expose the proximal carpal row as well as the capitate, the usual approach that is used is the Berger's ligament sparing approach. Now, as I said, there will already be, most often there would already be a capsular injury. And so the only thing left to do would be to try and extend it so that these flaps are made in such a manner that they would stick to the principles of a ligament sparing approach. You try to make rather than cutting through the dorsal intercarpal and dorsal radiocarpal ligament, we cut them longitudinally and raise these capsular flaps so that these ligaments can be repaired again. So once we do that, we try to extend and raise these flaps. That shows the scaphoid fracture. And unlike the usual scaphoid fractures, these tend to be quite unstable because of the ligamentous injuries all around it as well. So to hold reduction, you may have to use these joysticks so that these are held in place on both the proximal and the distal poles of the scaphoid. And if it is a pure ligamentous injury, then these joysticks would be in the lunate and the scaphoid separately so that you can bring the two bones together. Here, since it's a fracture, so we'll try and bring the fracture together. And of course, we reduce that, place the guide wires, including an anti-rotation wire. And so we start off with the scaphoid fixation. And once that is done, and we fix the scaphocapitate, and other fixations are usually just performed closed under the CR. And then we can have an extra wire in the triquetrum so that that can be flexed as well for or to bring you towards the lunate for a proper reduction for K-wire fixation. So when do you add a volar approach? The classical teaching has always been that if there are median nerve symptoms for more than 3 days is when you should add a volar approach, or we have a complete median nerve palsy, which is very, very unlikely. Usually patients have only paresthesias. And then, of course, the situation of a delayed fixation where you find that you're not able to reduce it because of the fibrosis, that some of the fibrosis may be on the volar side as well, and which would have to be removed so they can get an adequate reduction. So that's the volar approach. It's an extended carpal tunnel release sort of an approach, and we always find a there's a capsular rupture there as well. And you would, of course, find an injury in the lunotriquetral area also. Once you retract the median nerve and the flexor tendons away, you would find once you open up, usually you would also repair this with a simple sutures or a continuous suture on the volar side. So variants. So the simplest injury, or what we could call the simplest, but these are of course more difficult to heal, is what's called the lesser arc injury, which is a pure ligamentous injury running through all the ligaments only, and which doesn't really have any fractures. So all the ligaments around the lunate are injured, and that leads to what is the perilunate dislocation. And then, of course, what's called the greater arc, in which the force basically transfers the same, but instead of the ligaments, it goes through the bones. So that's where you have scaphoid fractures, can have capitate head fractures, and that is called the greater arc injury, or the perilunate fracture dislocations, or of course we just simply call them transscaphoid perilunate dislocations. The later ones recently described were the intralunate arc, where it is a ligamentous injury, but there's a fracture of the lunate, and these are actually extremely rare, but they can be very easily missed because they may not be so apparent on X-ray. Even when you open up, if we may not find the fracture properly, even in an open approach towards the perilunate injury. So, but then surprises are quite common. Every possible combination of injuries has already been described, and wrist surgeons have no real right to be surprised by any perilunate injury, but still, it's quite common that we find the sort of injuries which are quite unexplainable on how these happened. For example, you can have the radial styloid fractures are quite common along with perilunate injuries, but you can have fractures like these where bone fragments are lying in the carpal tunnel, or they could, for example, in this case, the scaphoid and the lunate were lying in the forearm. And of course, something that is now being described more and more commonly now is where you have a scaphoid fracture and a scapholunate injury. So that it's not just either scaphoid fracture or scapholunate, it's that you get both of these. These are, of course, quite difficult because the proximal pole of the scaphoid then is completely free. It is broken from the distal pole of the scaphoid, and it has no attachment to the lunate as well. And so reducing them, and obviously chances of avian are probably high, but again, literature has not come up with cases of avian in this type of injury as well. So just to go through these common variants, the lesser arc injuries. So we'll see what the principles that we had already seen. One is to, of course, first is to fix the scapholunate, which is the Mayfield stage 1 part. And here I've used 2 suture anchors because this was an intra-substance tear, and so use 2 suture anchors to try and pass your sutures through both the halves of the scapholunate and to repair that. And after the scapholunate, like we said, the next should be the mid-carpal. So here I've added to the mid-carpal, there's a scaphocapitate wire as well as a trichotillomere wire, so that stabilizes the mid-carpal joint. Then, of course, there are 2 lunotrichoterals, which finishes up the entire all the fixation all around the lunate, and which is classically what is being now called the diamond configuration of K-wire fixation for these injuries. And then another, I think, sort of common variant would be the transcapitate scaphoid. And when we look at this X-rays, something seems to be wrong apart from a scaphoid fracture, and that is that because on the lateral view you can see that there's a separate fragment apart from the scaphoid, and which is actually the capitate head. It's a fragment of the capitate head, and this is a sort of situation when you have multiple confusing fracture patterns is where we can consider the CT scan. Otherwise, no further imaging is really required for perilunate injuries, at least in the acute stage, for its proper management. But when we have these multiple fragments lying around and you're confused as to which goes where, it would be useful to get a CT scan before we go ahead with the fixation. So the point in these injuries would be to fix the capitate first. The capitate, the hamate, and the distal row forms part of the sort of stationary part of the wrist, and which because attached to the metacarpals. And so once you fix the capitate, you have a stable template onto which the rest of the proximal row and the rest of the wrist can be reduced and worked upon. Trying to fix a scaphoid fracture without going for a scapholunate ligament injury without actually fixing the capitate would be extremely difficult in these cases. So the idea for these cases would be to start with the capitate, create the stable base, and then go ahead with the rest of the ligament and fracture fixations. So that's how this was managed. And these can be quite unstable, and therefore we have added 1 wire for the capitate and the scaphoid in addition to the screws. So we have, again, the same principle goes here. We have one on the capitate and the scaphoid are the first ones to be fixed. Then you fix the mid-carpal area, then you fix the lunotrichoteral area. That completes the fixation all around the lunate. And that's at 8 months, when all the other wires, usually remove wires at around 8 weeks. So then, again, multiple variations are still possible. This was a complex lesser arc injury. You don't see any fractures, but it doesn't look like the usual perilunate, because the trouble is that the wrist is also now radially dislocated. So this is a radiocarpal dislocation as well. Apart from perilunate is actually in place and everything else is out of place. And that ulnar styloid fragment tells the story, because ulnar collateral ligament is avulsed since the entire carpus and the hand is now moved radially. So this again, because this was a delayed presentation after a week, required burn approach on both the sides. And there was a lunate avulsion of the scapholunate repaired with an anchor. The additional point here was that it required a radioscaphoid wire, because otherwise the radioscaphoid joint, even after the rest of the fixations, it will not stable, and the radius would keep going. The carpus would keep dislocating radially. So there was an option between an external fixator or even a spanning plate. I think a radioscaphoid wire was a simple solution in this case, and therefore we used that. And that was at 4 months, where the reduction was maintained. Even the scapholunate and lunotrichoteral reductions were maintained. So then you can have these delayed presentations, like I said, missed injuries common. I think thankfully now these are decreasing, which is quite unlikely nowadays to see these delayed presentations, but they can also occur. And this is 4 months post-injury. And we can already see that the capitate is actually lying against the radius. And so for these kind of cases, the salvage procedures, what do we perform? And for this patient, we did a proximal row carpectomy, basically just ensure that the capitate goes into its proper place when you do a proximal row carpectomy. The scaphoid, the fragments, and the lunate was removed. That is at 1 year, and a fair range of motion was then achieved at around 1 year. About 60% of the extension of flexion was achieved at around 1 year. Then just a quick look at the evidence. I had some systematic reviews come up in the last couple of years. This one is just this month, in fact, in 2023 October. What they found was that there is a 10% rate of reduction loss. For acute perilunate injuries, there's 10% loss of reduction and 10% reoperation rate for this sort of an injury. And there's a higher complication rate when you open on both sides versus if you open only on the dorsal side. In fact, open surgery has more complication rates than arthroscopy. And the complication include reduction loss and reoperation and everything. Now, the trouble here is that this the comparison is not so straightforward. There's a confounding factor that for opening up on both sides is usually a more severe injury than if you choose to open up only on one side. And similarly, if you're managing it with an arthroscopy, probably would be a less severe injury. And that is a confounding factor that has to be considered. That it was the most severe injury, so they had more complications also. But again, this seems to give an understanding, taking us towards an area where we should consider probably arthroscopic and less invasive methods for these management. And then another review regarding on the time delay and the effect of time delay on these injuries is that quite logical that if the best outcome is if it is operated early. The worst is when it is operated after 6 weeks. But then one other important aspect was that a close fixation of the scaphoid fracture and close pinning gave better outcome than acute fracture dislocation, that is a transscaphoid fracture dislocation. But this review found that in fact it's a pure ligamentous injury, then a closed or open surgery did not matter, both had the same results. So the take-home messages would be, yes, to look at the x-rays carefully. So that the most important step, I think, in managing a perilunate injury is to actually diagnose it on time and not miss it. And once you diagnose it, you would probably end up managing them properly. To remember the appearance on a lateral view, so not just for diagnosis, but as well as for how the post-operative X-ray should look after we have done with the fixation. Now, of course, remember the Mayfield classification for the Mayfield stages for the sake of knowing exactly where the fixations and exactly where the wire should be, and this should always lead to good results with these injuries. So, thank you. Thanks for the time.
Thank you, Ajeesh. That was a fantastic slides and presentation. So, as Ajeesh said, that that diagnosing it is the most important part. Because most of the time, like I happened to read in one journal that if you anything in hand surgery can be missed. Even a scaphoid fracture can be missed. Anything else can be missed. But the perilunate injury, if the treatment is delayed after 7 days, that is in 1 week, there is a 50% chance for the risk to go for a secondary arthritis. So it is very true that we need to diagnose it on time. Is there any questions for Dr. Ajeesh?
Can you explain DC and VC injuries? I guess one more session.
Yeah.
That's it.
He's asking in the chat box that can you explain DC and VC injuries? I think Ajeesh will require one more hour of session.
Oh, what is it? I didn't get that. The chat box? Okay.
There is a question there. Explain DC and VC injuries.
Oh, okay. So I will
one more session you'll require.
Yes, we have to do another Ask Wisdom Trail for that. Let's see what are these CNBC injuries. Yes. So should I go for that?
Maybe briefly you should.
Yes, sir. Let's see in a very short time. So the question, I think by the DC and VC, what I felt like, at least when I was a beginner, what I didn't understand is what is this intercalated segment? That is, if you know that only, then you understand what the DC is and what the VC is. So the thing was that the proximal row was considered the intercalated segment in the olden days when the initial anatomical studies were going on, especially the lunate, because there are no muscles or anything attached to any of the bones in the proximal row. So it was considered that this was intercalated between the forearm and the hand. So, and all the muscular and other attachments were to these two components. And this part was basically not attached to anything, but is intercalated between these two segments. So the VC and DC is actually quite simple when you see it that way. Is that a DC is when that this intercalated segment is deformed so that it faces dorsally, and VC is when it faces volarly. And now the complications again then arises when does it VC occur and when does it DC occur? I think when the thing to understand here is the lunate is an intercalated segment between the scaphoid and the triquetrum. So in that plane, when you look at it, and the scaphoid tends to flex, the triquetrum tends to extend, and the lunate gets carried away by whoever is more powerful. That's all it is. So if the scapholunate is injured, then of course the scaphoid has lost control of the lunate. So the lunate is going to extend, and we are going to have a DC deformity. If the lunotriquetral is injured and the lunate has lost control over the triquetrum, the scaphoid is going to flex it, and we are going to have a DC deformity. That is putting it very simply. And if you go any further than this, I guess you'll probably require a whole session on that.
Look at lunate, whether it is tilted volarwards
Yes,
or
yes.
tilted. That will
Yes,
give you
yes.
some idea. That's all you can briefly.
Yes, sir.
I have a question, Darshan. Do you undertake these ligament reconstructions around the wrist? And when you do that, what kind of graft do you use, or do you just use the tissues that are?
What ligament reconstruction? Are you talking about the DRUJ ligament or SL ligament, or what ligament you are?
No, in a perilunate dislocation, do you have to undertake any ligament reconstructions? That was my first question. Or do you just fix them with K-wires?
Yes, sir. So we would not ligament reconstruction as such. We would repair the scapholunate ligament. Yes. So that is why the open approach is considered. The reason for choosing the open approach over the close initially was that you can access the scapholunate ligament from the dorsal aspect. The dorsal scapholunate is the stronger and more important mechanistically, so that we try to repair that. And usually it's either a avulse of the lunate, and then less commonly of the scaphoid, and even less commonly it is an intra-substance tear. So depending on that injury, we try to usually repair it with anchors. Ligament reconstruction in the setting of a missed perilunate is extremely unlikely, because in that setting you would most likely do a salvage procedure like a PRC rather than try to reconstruct the scapholunate. For an isolated scapholunate, obviously you may go in for a ligament reconstruction, and then there are a whole lot of grafts and techniques mentioned for that, for isolated ones. But for in the perilunate setting, it's very unlikely that you would end up with a ligament reconstruction. Repair, definitely it is recommended to do a ligament repair.
Yeah, so because it's acute, you would most of the time find tissues there to repair, right?
Yes, sir.
The answer is about anchors in the hand. You were mentioning the anchors for scapholunate. So, what are the common anchors that you use? Because the drilling depth in the hand bones will be less.
So we have actually two sizes available. One is the Arthrex 2.2, and the other one is a Zimmer. You get something called a Juggernaut. That is a 1 mm.
1 mm, okay.
1 mm. So that 1 mm is used mainly for the scapholunate reconstructions.
So what is the drilling depth of those anchors?
For the 2.2, it is 3 mm, and and for the 1 mm, I'm not sure, sir, but it's less than 3.
Just in 1 centimeter, that's it.
10 mm, okay.
So we have the biotech anchors also, by the way, available. So we have 1.8, 2, and 2.3 in biotech. So those are something maybe a bit cheaper than the Zimmer one.
Depu also has got 1.3.
Depu also has
that was the only thing which was available.
Available, yes. So
Yeah.
few years ago,
Now we have good number of. Even this one has got, even ConMed has got that 2.1 mm anchors. So
Yes.
plenty. But 1 mm, there is not much chance. Only Zimmer Juggernaut is the only thing available, that size, with a shorter drilling length if you want to put into a lunate.
This lunate, we can't afford to put two big suture anchors.
Yes.
Yeah. So that Zimmer is an option. For others, like we have a lot of options.
So I think we've
Yes.
overshot the time a bit.
Yes, sir.
But the discussions were excellent. A lot of interest. Some closing statements from you, please.
So, to me,
Yeah.
okay, thanks all the speakers. It's been very informative, but very few forthcoming questions to actually explore further your knowledge. I'm sure like the three speakers are like well experienced and know the subjects in more depth. But whatever you spoke today has definitely improved our insight into the wrist injuries. which has always been a nightmare to most of us, most of the other scopy surgeons who deal with larger joints. And thank you very much, all the speakers, and for taking your time and effort to join this group of Arthroscopic AASK Kerala. And I'm sure like we'll meet more often in meetings that come across in our state and the national level. Thank you very much.
Thanks. Thank you very much.
Thank you, sir. Thank you, sir.
Thank you, all the speakers.
Thank you, sir.
Dr. Darshan,
Thank you, sir.
Dr. Ajeesh, Dr. Sreekanth. Thank you, Dr. Binoy. It was
Okay,
wonderful.
sir.